Mark Siomo and acting as chair this afternoon for the Council's Committee on Ways and Means. I'd like to remind everyone this is a public hearing and it's being recorded and broadcast on Comcast Channel 8, RCN Channel 82, Verizon Channel 1964, and streamed at boston.gov/city-council-TV. Please silence your cell phones and other devices. We will take public testimony in the middle of this hearing at some point, so please check in and sign up for public testimony if you'd like to offer it. This is a budget review that will encompass, it's part of our 34 hearings that we're having over roughly 6 weeks. We strongly encourage residents, whether here or in the chamber or at home, to take a moment to engage in this process by giving testimony for the record. You can give the testimony here in public or you can submit it via email. We also have a dedicated public testimony only hearing on Tuesday, June 4th from 2 p.m. to 6 p.m. We'll be here at least for that period of time. If public testimony extends beyond 6 o'clock, we will continue it. You can send your testimony as well by mail to the Committee on Ways and Means, City Council, 5th floor, Boston City Hall, Boston, Mass. 02201, or email us at ccc.wm@boston.gov. Today's hearing is on the Boston Public Health Commission. The focus is recovery services. It is regarding dockets 0622 to 0625, orders for the FY20 operating budget, including annual appropriations for departmental operations, annual appropriation for the school department, appropriation for other post-employment benefits or OPEB, and the appropriation for certain transportation and public realm improvements. This is also covering dockets 0626 through 0628, capital appropriation, including loan orders and lease purchase agreements. This afternoon, we are joined by the Director of Recovery Services, Jennifer Tracy, and the Bureau Director for Recovery Services, Devin Larkin. I'm also joined this afternoon by Councilor Ed Flynn. I'm going to turn it over to the two of you for presentation. Welcome.
Thank you. Good afternoon, Councilor Sabi George, Councilor Flynn. I'm grateful to be here with you all today. Since I was before you last year, the Mayor's Office of Recovery Services has continued to expand the scope of our efforts and has worked to meet the needs of our constituents. We've continued to address gaps in care and assist people in navigating the complex recovery services landscape. From street outreach to early engagement to accessing treatment beds to supporting individuals in early recovery, we've focused on each step of the recovery continuum. Thanks to Mayor Walsh's leadership and the City Council's support, our budgets have steadily increased since our creation in 2015. This has allowed us to create and enhance a wide array of recovery services citywide. This year, I am joined by my colleague, Devin Larkin, Director of the Bureau of Recovery Services. With Mayor Walsh's commitment and Health and Human Services Chief Marty Martinez's support, we are strategically combining and elevating our collective efforts to maximize impact and efficiency. While we have worked closely with Devin and her team at the Bureau since the creation of ORS in 2015, we are now formally combining our efforts to better meet Boston's expanding recovery services needs. This year, we continued to expand our partnerships with other city departments and community partners, from first responders to libraries to arts and Age Strong. We are working to make sure that recovery services are equally present across all city departments. While we have made a lot of headway, and based on the state's Department of Public Health data released yesterday showing decreases in Boston for fatal overdoses, we are optimistic, but there is still a lot of work to do. We remain in the midst of a national substance use epidemic that last year took more lives than the worst years of the AIDS epidemic, gun violence, deaths, or car fatalities. The devastating toll of this epidemic is seen not only in drug-related deaths and their ripple effects, but also in quality of life issues in our neighborhoods. Homelessness related to addiction, public drug use, and needle debris have increased over the last few years in urban centers all over the country. Cities across the U.S. are grappling with these quality of life challenges more than ever because they have never been as prevalent or complicated as they are right now. We highlight this national context not to minimize the issues in our neighborhoods in Boston, but to contextualize them in the unprecedented scope of our current national epidemic. In short, drug use in the U.S. has never been as widespread, visible, or deadly. In Boston, we have a coordinated multi-department response to quality of life issues. This includes mobile SHARP staff, street outreach staff, and mobile harm reduction outreach staff, all new investments since 2015. We've also trained multiple city departments and community partners. More than ever, our solutions to addressing the epidemic have to be comprehensive and versatile to meet Boston's ever-changing needs. Our goals for the next year reflect the need to make recovery services more sustainable and equitable. To increase sustainability, we are investing in better data collection, which will help us better evaluate our services, keep track of our progress, and maximize increased revenue across all billable services. On the equity front, we are working to increase access to comprehensive recovery services, especially to historically marginalized communities. Last summer, we released the city's first ever youth prevention strategic plan. It overwhelmingly focuses on racial equity, aimed at offering overdue holistic substance use support to youth of color. While overdose deaths in Massachusetts have slightly declined in the last couple of years, overdoses among Blacks and Latinos have increased. To address this, we applied and received a Federal Office of Minority Health grant, which has allowed us to expand outreach efforts in previously underserved communities. We realize that we cannot adequately address these issues without first naming the inequities in our communities and recognizing remnants of the failed war on drugs. Our recent Operation Exit Renew initiative offered men of color formerly incarcerated for drug-related crimes living wage employment at a local recovery provider, paired with additional support services. And finally, we continue to work to realize Mayor Walsh's vision for a recovery campus on Long Island. The need for a long-term, comprehensive recovery campus is greater than ever. We are in the early stages of a master plan process for Long Island, and we continue to take feedback from the community. Luckily, we have had a great amount of local support for the campus, including from members of this council, and we are hopeful about the future of that project. Thank you again for your continued support and advocacy of our efforts. We cannot solve these complex issues alone. We are confident that the year ahead will be filled with new opportunities, new teachable challenges, and progress in the areas outlined in my testimony today. Thank you. We're going to go through the PowerPoint now with some data and outlining some of the investments. So this is what we're going to cover today, the FY19 accomplishments, some initiatives specifically around needle response, and our FY20 goals. As I stated in my testimony, the opioid epidemic is a national crisis, a national public health crisis, and in 2017, we lost over 72,000 people in this country due to overdose deaths. Close to 1,262 or more in Massachusetts. Thanks to Mayor Walsh investments and the support from this council, recovery services budgets has increased over the last 5 years consecutively.
Some of our accomplishments for FY19 include expanding our access to care and harm reduction efforts. We were able to place over 7,000 people in treatment, and that's all modalities of treatment this year. We were able to provide, to expand our harm reduction services to meet the needs of over 8,000 individuals this year. And we were able to train 6,600 people in overdose prevention, which includes access to naloxone. Our citywide outreach team doubled this year. We were able to expand from 4 to 8 FTEs just in the South End Newmarket area. We also were able to expand our footprint of where we're able to reach constituents in the city. We received both a federal grant and an increase to our Care Zone project so that we were able to provide more hours in Dudley, Fenway, downtown Boston, South End, Upham's Corner, and Fields Corner, and we're hoping to expand that more into Mattapan. And we were able to increase collaboration and coordination with Sharps pickup strategies by adding capacity to mobile Sharps and the outreach team to provide more sweeps in the neighborhoods. Here you'll see the paths walk-in numbers and how the numbers have changed over the last year. You might remember that we expanded the paths hours to be open till 7 p.m. every night and also to expand to weekend. And you can see here what that's done for our ability to have more people placed successfully in treatment. You know, we know that when we closed at 3 and asked people to wait until the next morning to come back, we lost a lot of people by doing that, and so by being open to 7, we're able to successfully get a lot more people into treatment same day, or make the wait for 7 a.m. the next morning a lot shorter. The number of clients that we're reaching through our drug user health program has increased. This is due to the fact that we've been able to increase our outreach footprint and reach more people and more communities. This is a slide of our naloxone distribution numbers. So you can see by increasing our footprint across the city, we've been able to also enroll more people in the naloxone program, meaning people are trained in overdose prevention and how to reverse an overdose. And then this shows the increase in the number of overdose reversals that we have being reported back to us. So when somebody's enrolled in the community-based naloxone program, they can come back to us after they've reversed an overdose and re-enroll to get another, to access to more naloxone. And you can see that these numbers have gone up dramatically too over the years. We did another investment in the Engagement Center for FY19. We were able to expand our staffing to include more management of the staff. I think it was clear after the first pilot phase that the intervention was successful in getting people off the street. We were consistently at capacity in the space, and we needed a bit more infrastructure, so we were able to roll that out. We were able to purchase a van so that we were able to help people with transport when they needed to get back to a different neighborhood or needed to find a safe place to be for the night, whether it was a local shelter or the night center downtown. And we were, able to get more people off the street to address the neighborhood concerns around congestion. So the Engagement Center is highly utilized. We actually started opening up at 6 a.m. instead of 7 a.m. this past year at the request of the neighboring businesses. We're basically at capacity when we open every day. There's actually a line for people to get in. It's certainly busiest in the morning when there's the most demand for somewhere to be off the street when people are in the neighborhood accessing services. We were able to add 2 recovery coaches to our staffing pattern to help connect people to care. And we are also able to roll out a consumer advisory board to help inform new programming in the space and also to help with some cleanup efforts in the area.
So, thanks. Another FY19 investment through the leadership of Mayor Walsh and the council support. We released a youth substance use prevention strategic plan last summer, and the investment allowed us to hire staff to implement the strategic plan, as well as to coordinate activities across the city for the first time. So one of the focuses was providing evidence-based training and support to youth-serving agencies. We trained over 300 Boston youth, received this curriculum through community-based organizations. We've launched 2 learning collaboratives. One is a citywide learning collaborative for evidence-based practice for substance use prevention and young people, where we coordinate and meet with different sectors all over the city to share best practices in our work in schools and after-school programs. The other learning collaborative is a collaborative of collaboratives, and we have reached into the high-risk youth networks and other youth-serving organizations and coalitions in a different way. So historically, when we have worked specifically with youth-funded substance use coalitions, and we still do, and they provide a lot of leadership and content expertise, but there's a lot of other youth coalitions across the city that weren't part of this conversation, and we've created a learning collaborative to bring these folks together to share best practices again, and really building skills with young people. And we are starting developing a youth communications campaign, which started a few months ago with a consultant, and it continues now, and starting to do some testing around youth communication, driven and led by youth across the city. And of course, hopefully everyone knows that Mayor Walsh filed a lawsuit against opioid manufacturers and distributors in September of this year, and that continues in litigation. A core component of the Office of Recovery Services is to work across city departments and build capacity around recovery strategies in all different city departments. Here's a list of some, not all, where we are currently have initiatives with or work closely in one way or another. Sometimes it's education and resources. Other times it's training around how to pick up sharps or overdose prevention, or engaging in the Age Strong Commission, for example. We have worked with their volunteer corps to hold conferences around the opioid epidemic and problems associated with grandparents raising children and overall awareness. They also dedicated their April issue to their magazine around older adults in the Boston neighborhoods who are in recovery. So we will continue to focus on expanding these partnerships and engaging the community through our other city departments. And we have, of course, one of the first partnerships that we've developed when we came on board were public safety partnerships. And we have a lot of work that we continuously do with our public safety partners, EMS, Boston Police, and Boston Fire Department. Some of our significant partnerships are the post-overdose response team with the Boston Fire Department, which allows a public health professional harm reductionist from recovery services to team up with a recovery coach from the EAP team at Boston Fire and respond to overdoses that occur in homes throughout the city and offer access to care, education, and support. EMS, I know you'll hear from Chief Hooley in a couple of weeks or next week around the Squad 80 to provide more assistance and support around homeless and addiction issues. And the Boston Police Department, Deputy Superintendent Stratton, and before him, Deputy Superintendent Cotter, taking a focus across the city and helping to support the issues of homelessness, recovery services, and mental health issues has been primary to us really working together to deal with the public health and public safety issues that we face. And so we continue to do support their initiatives. So we wanted to really just bring forth one of the most concerning issues and results of the opioid epidemic, which is quality of life issues and needle debris. Prior to 2015, we want to make sure people understand there was no City of Boston policy for needle pickup. Since that time, we have consecutively added folks to run the Mobile Sharps team, and I think there's a lot of confusion sometimes around our effort and our strategy across the city around Mobile Sharps pickup. We do have the Mobile Sharps team, which is now at 4 individuals that are exclusively responding to 311 requests across the city. That obviously is not enough support to help us and to collectively have an impact on the issues. We have added, as folks know, last year, Mayor Walsh invested in, with the support of the City Council, 2 years ago, the street outreach team in the Mass Cass area of Boston. That has now doubled with an investment mid-year through this past year. And those folks are all, part of their outreach is also picking up sharps in the neighborhood. So we've added to the team 4 + 8, as well as community and private providers who have joined the effort. So this is an iterative, ongoing, every year building to make a stronger team and really to tackle this all hands on deck, because that's the only way that we can have an impact at all. And so through funding, through private funding, we have Project Place staff that are working in the area also, as well as the entire staff that does outreach at the Recovery Services Bureau, so those folks that are out in all those neighborhoods. Other city departments are trained and continue to be trained. We consistently are working with, first and foremost, Parks and Recs Department, DPW, but other departments as well. Certainly BPS custodians, BPS faculty that do playground duty, we've provided trainings for as well. Over 400 custodians have been trained through the Environmental Health Bureau and the Recovery Services Bureau. In addition to that, we have find that there was a need and a request from the community to install more needle kiosks throughout Boston neighborhoods. And in response to that, we had a mid-year investment, again, to purchase additional kiosks. And so when the Office of Recovery Services opened in 2015, the city managed 4 kiosks across the city. We are adding to those. Every year we've added 1, and now we've purchased additional ones. We don't have locations identified for all of those. We have requests that have come in from communities that we will work with them and abutters and neighborhood associations and city departments to really locate the appropriate place to install them. So in the case of Orchard Gardens, which the kiosk has come up a lot with folks, the initial one, about a year ago, there was student advocacy that happened with the students and teachers at Orchard Gardens, and one of the requests from that group was it was a kiosk. We met with the leadership at the school, and under the guidance of BPS as well, did a walk around in the area with leadership from Orchard Gardens, ISD, Parks, someone from the Parks Department. I think Councilor Baker was, there you are. You were there too, and just kind of walked around to locate an appropriate space based on the request. And we did that. I think folks should know that, that has been controversial, and I think we're open to talking further about that. If it needs to be moved, it should be moved. Right now, I think we're seeing, are people using it, and is it effective? So I think we'll continue to monitor that and to work with the with BPS and with the school community on that. And we've also contracted with the new 24 Trauma to do the disposal in hopes that that will relieve some of the 311 staff, the mobile sharp staff that responds to 311 calls, who historically have also been responsible for emptying those kiosks and going around to the different locations. And so as we add more, we want to relieve them of that, have the 24 Trauma do that piece of the work, and so that frees them up to continue to exclusively respond to 311. So these are all pieces of really thinking of a larger strategy than just positions. And I don't want to forget the last bullet there, the very recent Needle Take Back Day that was initiated and led by Councilor Sabi George. We participated in that, and it was the first, and it was an experiment, but I think we look forward to continuing to work with all the councilors on creative ideas to collectively address this issue.
That's it.
Go forward or no?
Yeah.
Okay. So to some of the FY20 new investments are to continue the work on improving our collective response to mobile sharps, most of which I think I just addressed, and enhancing data and revenue systems. So addressing data and coordinated data across recovery services. Right now, we have separate programs collecting separate data, often on paper, and really to be the most effective, we need to improve that system for data so that we can better report on what we're doing and report to all of you. You could talk about some of this, but substantially increase revenue. There's a lot of missed opportunities right now with our system around not capturing full revenue reimbursable components in a electronic medical record, and improved data system will help us do that. And also, they're required by licensing and regulatory. Other FY20 goals, just increase equity in care, focus on increasing equitable access to care with a focus on communities of color, veterans, LGBTQ community, and survivors of sexual violence, as well as continue to focus on expanding long-term recovery supports that keep people stabilized, workforce development opportunities, stable housing, employment opportunities as well. And then with the FY20 investments, we will expand our community engagement team. And Long Island Recovery Campus is a major FY20 and beyond goal, so we're currently involved in that process as well. Thank you.
Thank you very much. During your presentation, we were joined by a few additional colleagues. I'd like to recognize in the order of their arrival, after Councilor Flynn has already been here, Councilor Campbell, Councilor Frank Baker, Councilor Janey, Councilor Wu, Councilor Edwards. So I just say thank you for including the Needle Take Back Day in your presentation. I also thanked Director Valdez-Lupi earlier today just for your partnership through your office on that day. We had 17 additional sites across the city taking back needles. Some were quiet and some got overloaded, and we had to give them more supplies to continue collection. So I think it was certainly a good experiment, a good effort, and one that we're going to hopefully do a little bit of a report back on the effectiveness of that day. And that sort of follows along some of my work around advocating for the Mobile Sharps team, which we were able to double the capacity 2 years ago. So can you talk a little bit about the investment in Mobile Sharps and what it gets us? So how many needles are they picking up? What's the return that we're collecting in the kiosks, and how we're looking to build their capacity going forward? What's the real number that we need?
Well, I'm going to answer that backwards, but I think that I just went over a few ways that we are thinking really, I think, in a larger way around Mobile Sharps pickup, and that's a collective effort across city departments, increasing the capacity for city departments to also pick up needles and support that strategy. As well as the Mobile Sharps, as well as working not only first and foremost, which we have with our outreach staff, of which there are outreach staff that cover Mass Cast, there's outreach staff that cover neighborhoods downtown and in other neighborhoods, and increasing the effort there for folks to collect Sharps. And we've had a number of private community providers who work with us in those neighborhoods and have offered support as well. So in the Newmarket area, there's a private business that has joined the effort in the Mason and School in Orchard Garden and does a sweep once a day to add to that effort on both those school grounds. We have Rep Santiago is advocating for resources in the state budget right now to add a position that Boston Healthcare for the Homeless would collaborate with us on adding a person. So again, expanding sort of the way that we think about a collective effort around receiving Sharps. But I think I'll let Devin answer some of the specifics around how we're collecting and the amount.
Yeah, sure. So right now, the 4 FTEs that are devoted to Mobile Sharps are really the 311 response, and so they're on the road across the city responding to the 311 calls as they come in, and they really do come in from every inch of the city, and they do take a customer service one-to-one response, because sometimes there's constituents there that want to point it out, might need a call back, and so you really need a staff person to do that work. What we didn't need necessarily a city staff person to do was to empty the kiosks, and so we've been able to vend that out to a vendor. So that's going to alleviate a lot of time off the Mobile Sharps team to better respond to 311 and to do some of the proactive sweeps that they have scheduled right now in places like Orchard Gardens and Clifford Park. Now, the Mobile Sharps team are not the only people that are responding to some of those areas, and so we've been able to, through training and a lot of community partnerships and neighborhood association partnerships, add to the Mobile Sharps, FTE capacity by sharing some of those sweeps and timing them out at different points in the day. So Parks and Rec, have agreed to do sweeps at certain parts of the day. Our outreach team will take other 2 parts of the day, and then Mobile Sharps will take parts of the day, so that we have a consistent presence across the departments and just to get more bang for our buck, so to speak, based on staffing. We've also been able to train all 400 custodians at BPS schools, and they're generally the first people on site in the morning, often starting sweeps as early as 5 a.m. And so just making sure we're in touch with them regularly, especially for some of the schools that are the most hard hit. I think we feel like that's where we want to invest so that we just have as many boots on the ground as possible that are trained and prepared to respond if they see a syringe.
Right. And then what about the collection numbers? What are we bringing in? Because when I started this work 3 years ago, now 3.5 years ago, we thought the number was 9,000, then we realized it was 20,000, and I think it's potentially into the hundreds of thousands.
Yeah, so we collect syringes from several different sources, obviously the team in 311, kiosks, and street outreach.
So do we have those broken down?
Yeah, we do. And so
Great.
right now we're seeing anywhere to about 12,000 to 16,000 syringes a week that we're collecting through those different sources.
Between the three, a week?
And well, and obviously the exchange too. The highest volume is what actually is physically brought into the Finland building.
And that includes, I'm sorry, so that's Mobile Sharps,
That's AHOPE,
which is Needle Exchange.
Needle Exchange, Mobile Sharps, the outreach workers on Mass Cass, and the kiosks.
And the kiosks,
Right.
those 4 places. And do we know from the 311 calls, so community initiated, how many we're picking up?
It's about 2,000
A week, day?
A week.
A week, okay.
a week.
Great.
Yeah. And that does include 311 calls that we might get from a police department or a fire department who have gone out and collected some syringes and are giving us bulk, in one time.
Great, thank you for that. Appreciate that. Councilor Flynn.
Thank you, Councilor Asabi George, and thank you to Jen and to Devin for your great work on this difficult subject. For active users, a higher risk for the spread of HIV or tuberculosis. What are you doing on that type of outreach to our users that may be likely to contact a disease such as HIV or tuberculosis?
Sure. So our drug user health harm reduction program, AHOPE, is actually trained to test for STIs, HIV, and HCV, and they can do that actually on their mobile outreach routes. We've recently partnered with Healthcare for the Homeless to roll out a project called the Care Zone Van. So now on some of our outreach routes, when we're out and about in the community, we also have a doctor with us, and they can do a medical visit on the van. What we're trying to do right now is really proactively push for testing, like anything we can do to test as many people as possible so that at least we're able to detect early. We're also really encouraging for people that we know have really high risk to, get pre-exposure prophylaxis. Anybody who is willing to engage, we'll get them same-day appointments at either Healthcare for the Homeless or Boston Medical Center. And for people, if they come back positive, obviously we're looking to engage them in treatment as soon as possible. There are times when people aren't ready to engage at the time when they get news like that, but we kind of stay close. And the moment they're ready to access care, we'll go to the appointments with them, or we're right there with them.
Thank you.
Yeah.
And my final question, with every department or a lot of people focused on this issue, it can be stressful at times doing this type of work for our people that are in the field often. What are we doing for those dedicated city employees that are working on this issue, 10, 12 hours a day, 5 days a week. How are we being responsive to them in terms of their needs of their counseling or their time off, or their letting them take a break, making sure that they're okay, because it is a difficult task that we're asking them to do.
So, yeah, I don't think we've ever been in a time in this field where the workforce development shortage has been quite what it is now, and I think that's largely attributed to burnout, and the work has gotten so acute that a lot of people aren't able to stay as long as they once were. And so, we've been troubleshooting that with many of our partners who are experiencing the same thing. One of the things that we have been able to roll out this year is to have a trauma responder on staff. So a clinician, a mental health clinician who is trained in trauma response specifically, to be actually embedded in our programs 4 hours a week. So she's able to do coping groups with the staff and one-on-one appointments. And if somebody needs a bridge to a therapist, she can do that too, but really helping anybody who's experiencing any kind of symptoms of trauma to step back, have an appointment with her, build some skills around self-care. And that's a new initiative for us, but that's something that we've been able to roll out this year, and we're hopeful that that will help us with some of the stress and the burnout that we're seeing. But we're acutely aware that our biggest resource is our staff,
Right.
And if they're not okay, then they're not going to be able to take care of anybody. So, always open to suggestions on that front, but I think it's something that we're trying to pay a lot of attention to.
Thank you. That's all I have. Thank you for the great work that you're doing.
Yeah, thank you.
Thank you, Councilor Flynn. Councilor Campbell.
Thank you, Councilor Sabi George, and Devin and Jennifer, thank you for the work that you guys do. Clearly not an easy job. You're responsive to when we call, frankly, seeing you everywhere. So really just wanted to express my deep gratitude for the work that you're doing. I also wanted to thank, of course, people who are sitting up there, and then those who are out actually doing the work as well, who couldn't be here at this budget hearing for the work that they do. Just following up on Councilor Flynn's question, which was similar to mine, but I'm just curious, what are sort of the Mobile Sharps people paid?
Sure, so.
In addition to
Yeah.
the supports and the trauma supports?
So the Mobile Sharps team are part of our SEIU programs unit, and they come in as public health advocates twos, and so the average rate that they're paid coming in would be anywhere from $38,000 to $40,000 a year.
And then the person who is, I guess the title might be a mental health responder, this trauma person who's focusing on the well-being of the folks doing this work. This person is a full-time employee in the department, in your department?
No, we've contracted out
Okay.
with a group called Riverside Trauma Center, who's really specializing in this work. They're working with a couple of other folks in the field, like Hope House and Healthcare for the Homeless, looking kind of to develop the most appropriate model for response, especially with people who are on the ground. And so she's 4 hours every 2 weeks.
4 hours every 2 weeks?
Yes, and then also available to respond if we have a critical event, like a death on site or that somebody's responded to. She's also able to respond in real time or send somebody else to come and kind of do the immediate follow-up with staff.
Is there any appetite by your department to try to bring someone internal, sort of on a full-time basis, to respond? Or do you think this is sort of adequate?
Yeah, I think it's new, and I think we'll see how it goes. And if we're seeing a lot of benefit from it, I think we'll work with Riverside to figure out what would a full-time person look like, and would it make sense to have them in-house. I think we initially thought because having somebody who was working directly for the commission might be a little bit of a conflict of interest, so to speak, that people might not want to go to somebody they perceived as their supervisor to talk about certain things. Obviously, they're always welcome, but we wanted this person to really be a neutral kind of person in the space. And so this is how we're trying it now, but we'd be open to seeing what the best way is to move forward.
Remind me what your total budget is in your department?
You know the final number?
The total.
It's just over $7 million in city funding.
7 million?
Yeah.
What was your proposed budget? So the budget that you guys submitted hoping to get, was it 7 million? Was it more? Was it less? I mean, every department obviously puts forth a proposed budget. We have to do it even as a council to the administration. Curious what your proposed budget was.
It was about twice what the investment this year is $500,000, City of Boston dollars, which is a major increase for the Office of Recovery Services since 2015 of City of Boston dollars. Every year we have gotten more and more, starting out with the budget just for the office and the 2 staff at, I think, 3 staff at $300,000, and then consistently going up.
I only ask because it gives us a sense of, from where you sit, the work you're doing every single day, what you think you might need in order to do what you envision your department would like to do in the next fiscal year. So that's why I was asking sort of that question.
Yeah.
But one thing I did want to also applaud is and you really talked about this, Jennifer, your commitment to equity in this work, frankly, naming the what happened as a result of the war on drugs and how it was not effective, particularly in communities of color. I appreciated you naming that and showing up in the work with that deep understanding. Also looking at the dramatic increases in overdose rates among Black and Latino residents, of course, is always unsettling when you pull apart the numbers and see that it's worse for people of color. That's always just unsettling. So I appreciate your couching it in certain terms, but really using that equity lens in your work. And I'm sure I'm going to beep, but so just one question with respect to that. There's a federal grant that you guys applied for that you got. You're using it to expand your outreach into certain communities of color. Immediately when I looked at this geographic footprint, I always expect to see, when you think of communities of color, Roxbury, Dorchester, Mattapan. Don't see Mattapan or Codman Square, which is in my district, and Dorchester, of course. I got Franklin Field, Franklin South. So curious what the strategy is to expand to more communities of color, to have a greater touch and outreach to those communities.
So I'll let Devin answer some of the details as well, but the Minority Health Grant was specific to expanding in 3 neighborhoods, Dorchester, Mattapan, and Roxbury, and working specifically with some health centers in those neighborhoods to increase their capacity to work with active drug users. And so as part of expanding harm reduction strategies across the city, that was one of them. And so that's one effort. The other effort, as Devin mentioned, was the expansion of neighborhoods that the Care Zone van and the AHOPE staff are looking to do. You can talk a little bit more specifically about that.
Yeah, so for street outreach specifically, where we are focusing in areas where people gather on the street, so we can sort of find them in that way, and that's kind of how we're rolling out first. So places like Upham's Corner and Fields Corner, there is a need there for actual street outreach and working with the businesses there, because people do kind of hang out in those areas. We're finding that Mattapan Square, where we've done some outreach, it's a little harder to break into. There's just a lot less people on the street willing to engage, and we know that it's going to take some time. We've been in Dudley for about 15 years, so we have really good roots there, and we're expanding that footprint and kind of adding hours there. But one of the other things that we're doing as well is home visiting post-overdose. It's just another kind of way in the door, and obviously not everybody's going to be able to engage that way or open the door, but we're hoping by expanding both home visiting and street outreach in those communities that we're reaching more people. We're also connecting with the local health centers around how can they expand access to care for those folks from front door on. So being able to provide those services on site, but even how do you build a friendly environment and a culture that really welcomes people in when they have a substance use disorder, right from the front desk person on. I know you mentioned Codman Square. They're probably the most ahead of the game in that area. They're wonderful partners to us, and we refer there all the time. But we'd like to see that in all the health centers in those neighborhoods.
Thank you. I can wait for the next round.
Thank you.
I would just add to that some of our partnerships that also get at the same thing. So the police-assisted recovery coaches, the Perry Initiative, where recovery coaches are teaming up with the police department, but as recovery coaches in different neighborhoods. And so that's, they're in other neighborhoods as well, and we coordinate and collaborate with them. They're also have teamed up with police to do ride-alongs to be able to address some of those needs out in the community. So there's what the staff at the Bureau of Recovery Services do, but there's also, again, what other city departments are starting to pick up in the space of engaging communities and around the recovery services. Actionable items that they can do.
Thank you.
Thank you. Counselor Baker.
Chair. Good morning, ladies, Devin and Jen. Thank you for what you guys do with, you're shoveling a lot. So there was, in 17, there was 1,262 deaths with, and it has naloxone distribution at 4,361. Is that just what we handed out, or that's not actual uses? Is there any place where we can see what's actually being used for naloxone?
Yeah,
Because
so-
in 19, it was 16,000 distributed. Do we have any sense of?
Right, that's what that. Well, so what we know is what we get from the report back in the reversal. So when somebody comes back in and says, I'd like another dose of naloxone, we do a brief screener of kind of like, tell us what happened. And so we collect some of that information about when did you use it, where did you use it. So things like, we know zip code and we kind of know the basis of what happened. And one of the important things that we ask is, did you call 911? And so right now we know that at least half of the people that we're serving are not calling 911 during an overdose, which is a whole other issue that we're actively working on. And so we don't know what happens to every dose that goes out the door. We know every person that comes back to us and reports an overdose.
Yeah, we might have a sense of it, but not, you're never going to be able to get a true number on that.
Everything that happened with those
But the
16 doses.
over 2 years, we're up to 16,000 now. That shows that we're at least getting it out there and hopefully are saving lives. 7,425 placements, most of those detox.
Yes, yeah.
So-
Still about 50% are detox placements, about 20% are CSS, TSS.
That's the step down,
Those are step-down programs.
20%, and
Yep.
then residential is.
The rest would be residential, and then appointments for medication-assisted treatment, or any other type of assistance people might need. We're working very closely with the BEST team now on diverting people sometimes into that system if that's really where they need to go first.
Yeah, so we were here yesterday with Superintendent Stratton, and he said that, and it was an alarming stat that out of 8 people coming out of detox, we only had 1 step-down bed for them. Was that a correct?
Yeah, I would say that that's improved a bit. It used to be, I want to say it was more like 1 in 4. I can get you the actual data on the bed availability. But the state has actively put more CSS beds online in the last year and a half. So I actually see that getting a bit better. We're still having
Where are they coming from? Where are they're coming online? Where are they?
across the state. They've increased CSS capacity. So Stoughton increased their beds.
Right.
Tewksbury increased their beds. So they've increased bed counts in different programs.
Yeah, we're still seeing far too many people that return from detox without a place,
Without someplace to
without
go.
treatment on demand. When they're ready, as they complete detox, there's no bed available for them many times. And unfortunately, we often see them back to our program so that they come back in. They may have completed detox, they may have left early, but they're still interested in care. And so that's part of the PATHS numbers of the 7,400. So we see a lot of those folks.
That was my next question. So those 7,400, those are just PATH numbers?
Those are just PATHS numbers. So those are not numbers from the Mattapan campus, the residential programs that we serve. Those are the access.
So what is an AHOPE client then, as opposed to a PATH client?
There can certainly be overlap. It could be that
Yeah.
somebody, was a needle exchange AHOPE client for a long time, decided they wanted to access care and was able to do so through PATHS.
Okay. Good job on the shops. Can we talk a little bit, that a couple years ago, we didn't have any shops team, and we would send out either ambulances or fire trucks, so that just getting the shops team, now we have 4 of them, we probably need more, but can we talk a little, I know you did the contract for the 24-hour trauma biohazard, they do kiosks, and so like major cleanups, that would be by train stations, do they have a set schedule of what they, like, is there a major cleanup day you know, any place that they go to every day first?
No, they're actually on contract. They have a lot of different contracts in Boston. They work with certain BHA housing developments, so they're in Boston. They're always pretty close by. When we have needed them for a major cleanup, they almost always have people in the neighborhood that can help almost immediately.
Yeah.
And so we're not quite sure how often we'll need that type of help, but at least we have somebody kind of on contract, ready to go, should we find an area that needs a cleanup that's far beyond what Sharps can do.
Yeah.
You know, we want that response to be as quick as possible. And so just having them on contract, I think, will help us have
Yeah.
a better response.
Thank you.
All set? Thank you.
Not really, but I'll stand down.
Thank you. Counselor Janey.
Thank you so much. Good afternoon, everyone.
Good afternoon.
First, I just want to thank you for the work that you do every day. We know that we have a crisis on our hands, not just in Boston, but across our country. Listening to WBUR this morning, and there were a couple of stories talking about this crisis and what people in different cities are trying to do about it. I wanted to just follow up on some of your comments during your presentation. You talked about the proactive sweeps. How often are you doing them?
Well, it depends on the area. So if you're referring to Mass Cass area, our team specifically are doing 2 sweeps a day in the morning at Orchard Gardens and at Clifford Park and Orchard Park and Mason School, and then 2 in the afternoon.
So you do 2 sweeps a day at Orchard Garden School?
We do 4 at each place.
4.
Yeah.
Oh, and I would add, as part of the partnerships that are happening, so that's the team there. Again, there's a private partner in the community that's doing a sweep, and that is, will text us how many needles they find so that we can add that to the count. And the custodians at the schools are doing sweeps
And
during
did
the
you
day as
mention
well.
Parks, I think, in your?
And Parks and Rec does
So,
first thing in
yeah.
the morning.
For
And Parks
Clifford
as
Park.
well. In terms of the kiosk that is there now to capture needles, discarded needles, how many needles have been collected? How often is the box checked? Are there still needles on the ground, even with the box there? Did we see a decrease in the number of needles on the ground, given that we have the box there? Do you have that data yet?
We're working with 24 Trauma really to monitor. They're very new, and oftentimes, you know, it takes time for them to be used fully, although Devin can share a story about, I think, the first week that we had the Orchard Gardens one out. But right now, 24 Trauma and staff are making sure that they're not filling up, and they haven't. I don't think they've emptied a full one yet, but we're monitoring that. These are new, and so that's what we're doing, is collecting the data.
Have we seen a decrease, I guess, in the number of needles on the ground, either in the grass area, on the sidewalks?
So I would say
Because
that...
with the kiosk there, have we
Sure.
seen, or is it the same number
Sure.
that we see on the ground?
No, actually, since BPS instituted some of the responses that they put online with having Monday morning, their citywide cleanup crew does Monday morning sweep themselves, as well as some of the 5 different sweeps or 6 different sweeps a day. Once those folks came together doing a collective effort, we do see a decrease in needles in the area. Are there still needles? Yes, absolutely.
And I know there's still needles.
But yes, we have seen a
And what I'm
decrease.
trying to, I guess, ascertain here is whether or not the box is making a difference in terms of the decrease
Yep.
in needles on the ground, or do we see, so when these people are coming in to do their sweeps, are they picking up the same number of needles that they were picking up, you know, months ago before the box was there, or are they seeing a decrease because the box is there? That's what I'm trying to understand.
Yes, they're seeing a decrease.
Okay.
And we've been reporting on that. So BPS has seen a significant decrease in the number of sharps they're picking up on school grounds. Yes.
And is that true for your team as well?
Is that?
Yeah, I would say it's definitely, I think the collective efforts, everybody's seeing less every time they go out because there's just more effort into constantly sweeping the area and there's more people using the box. So I think all of those things together, particularly the 5 a.m. sweep that they're doing in Orchard Garden, where it's the citywide grounds crew, I think, that I think has made a tremendous difference because they're also cutting back the brush.
The 5 a.m. sweep?
Yeah, which is where I think some things were getting lost when there was overgrowth, and so I think we've seen a really positive increase since they instituted that.
I mean,
And
you
I
know,
guess how much of the decrease is because of the 5 a.m. sweep versus people are putting needles in, and people who are using needles and then putting them, so when I've witnessed people using needles, after they inject, they're not really in a state to put the needle in the box. They're usually in a state where the needle may fall out of their hand or what have you. So I guess how much of it is due to the 5 a.m. sweep versus the kiosk is there, and so people are being mindful and not littering their needles, but putting them in the box?
I think,
Or is it a combination of the two
I
things?
think it's hard to.
yeah, I think it's a combination of the two things. And to be honest with the kiosks, I think what we see in our peers is that one person will kind of take responsibility for cleaning up an area and use the box. And so, yeah, some people are very impaired, and that's not what they're doing at the moment. But they're usually with a group, or there's a group nearby, or somebody that's taken on the responsibility for kind of cleaning up, and will use the box.
One final question, if I may.
We'll do it in the next round.
Well,
Counselor
I'm
Wu.
not going to be here in the next round. Just, I wanted to know
I'm
that.
sorry, we've got lots of counselors
Okay.
here. Counselor Wu.
Yeah. I went to this by zip code.
Okay, so I'm sharing some of my time because I don't have that many questions. 2,000 needles per week collected in the city. Could you share by zip code?
Sure, we can give you that data. It's all, the 311 data is all publicly available.
Great. And so following up on that, what is the best place to track the data in terms of kind of box by box or kiosk by kiosk? How many needles are being picked up and kind of how it's trending over time?
So that's something that we were collecting on our own and reporting on our own a week-by-week basis. Now that we've switched to a vendor, they're basically giving us a weekly report of what they're finding in each of the boxes.
Are those publicly available somewhere, or will there be kind of a report looking back after a certain period of time? Or
Yeah, I mean, I think we're open to doing that. We do report it out to various different city departments, but we could post a report out online too.
Okay, great. I would love to follow up
Yeah,
on that
happy to
piece.
do
Yeah, again, similarly, trying to understand the dynamics of, all the different efforts being concentrated and what's working and where and how much. And then just for a minute on kind of resources when it comes to addressing trauma that the community might be absorbing. So, we heard a lot from Orchard Gardens family and just the community in general that a lot of the students are kind of not knowing how to deal with or might be feeling scared or anxious about what they're seeing on the way to school. Is there a way to partner, and maybe this is for the rest of the Health Commission, not necessarily this office, but is a way to support more ongoing communications and resources on that front for that community?
Yeah, absolutely. We'd be happy to work with them. We can do it in coordination with other services that are available at the Health Commission or our own team. We have a youth prevention team now that, and we've discussed some of that because this is because of the epidemic and what people are seeing out on the street is very, disconcerting to many folks who are seeing it, particularly in certain neighborhoods. And so I think that is something that we need to explore more.
Great, thank you.
Happy to talk to you more about
Okay,
that.
perfect. And then finally, so I may have missed it when you we're going through it in the presentation earlier, but what is the plan for the Sharps team kind of going into the next couple fiscal years, and what is your ideal number of staff?
So the way that we're looking at it right now is really expanding the capacity of not just Mobile Sharp's response to 311, which is what the 4 FTEs is, and really having that direct customer service response, but also expanding the collective effort and working more with our partners, private, public, neighborhood associations, city employees.
So I guess asked a different way and following up on what Councilor Sabi George was talking about earlier in terms of the number. So what is kind of what are the goals for, or how you would measure success in terms of, or at least, meeting need in terms of how many needles or the capacity of the team and all the collective efforts to be able to pick up those needles? How many needles, how much more of an increase are you hoping to meet in the next couple years?
I'm not sure I understand the question.
I guess, so given, you said there's 4 FTEs plus all
Yes.
these other resources
Right.
going to pick up
Right.
needles. Are we meeting half of the demand that's out there? Or do you think that we need to kind of double that capacity through a combination, more partnerships and staff? Or is it, what is the level of growth that we need to see there?
Yeah, I mean, I think we're monitoring that closely. I think that the 4 FTEs are adequately able to respond to 311. The response time is very quick, and so that piece is actually working quite well. I think determining, we're rolling out all these new efforts, and if the sweeps of the parks are still not working, then we might have to add FTEs somewhere. Where the right place is yet to be known. Like, is it that we need more people in Parks and Rec, since they're already in the park, to be able to pick up syringes? Like, where do we need to put the FTEs, that they're on the right team, I think is what we're really focused on now. And then, if we feel like the volume for 311 goes up this year and we're then not adequately able to address the needs, then we'd ask for more mobile sharps people. I think we're really paying attention to what's happening at nighttime right now. There wasn't a need at nighttime before, there is now. And so that's something we'll be paying close attention to this year.
Got it. Thank you. Thank you, Madam Chair.
Thank you, Councilor Wu. Councilor Flaherty.
Thank you, Madam Chair, and just a note to thank Jen and Devin for the great work that you guys do. I know it's never-ending, and you've encountered difficult circumstances on a regular basis, as well as working with us here on the council and our constituents across the city. So you guys do a great job, and just want to make note of that. You also know I've been a long-time proponent of recovery and treatment on demand, and also one that wants to put pressure on our suburban counterparts to step up and to do their fair share by way of recovery resources and in beds. It seems to always fall on Boston, and I know one of the big issues we have is you really need to take the kid kind of out of his or her element and put them somewhere. And oftentimes you see we have a lot of great recovery places here in the city, but we're also housing, children and men and women from other parts of the Commonwealth. We wish it was reciprocal in a bigger way. So that will be my footnote. So we're at really interesting times. Like yesterday, Jen, you and I and Frank, we had attended, and Councilor Flynn had attended an event, and the part where we got together was right around the Jewel and around tobacco smoking. And yesterday here on the council, on the floor of the council, Councilor O'Malley and Councilor Asabi George put together a hearing to discuss that. So we're in Boston. I don't think you can't get a cigar anywhere these days. We're cracking down on the Jewels, but pot shops are going to be popping up left and right. And so you guys are in the recovery world. What efforts are being undertaken now to prepare for the THC onslaught that's coming? It's the pot bonanza. And when shops start opening up left and right, kids are going to be getting their hands on this stuff more readily, not just in the smoking form, but also in the gummy bear and the brownie and the cookie and the candy form. But I guess what efforts are we making with respect to recovery services to prepare for that? But a lot of folks fail to recognize that THC is highly addictive, and our residents, particularly our youth, are probably going to get their hands on this thing sooner rather than later. And strange that we're banning smoking items, and we don't want cigar smoking, but everyone's taking a pass on the pot shop. So I'd really like to get your thoughts if you're preparing for this, and if so, what efforts can we do as a council to help you address the highly addictive THC that will be coming to neighborhoods throughout our city soon.
Sure. I would say most all of our efforts are focused on youth, families, caretakers, and youth-serving agencies and workers, people who are working with youth, regardless of where. So whether it's a community center, BCYF Community Center, or Boys and Girls Club, or schools, or parents themselves. So our efforts are really focused on, from the investments from last year, to increase our community engagement with youth. We had the prevention investment last year, hiring the staff who's able to, and you met actually the whole staff yesterday at that event. But I think, that's what we're focused on. We're focused on training adults that are working with young people on how to have conversations around drug use that aren't not penalizing young people for their use, but really having real conversations about where they're at and how to make healthy choices and decisions. And we're working across different sectors. So even at the Boston Public Health Commission, where they're doing work in neighborhoods with youth on trauma or on peer leadership, we're working with those folks who historically really in the substance use world we haven't coordinated in that way. So we're working closer together with different youth serving agencies, and then young people themselves. having activities and events where young people can talk about some of these issues and do proactive work to just be more informed and educated.
I just want to make sure it's not getting lost in the shuffle. We've been focused on opioids, we focus on tobacco, we focus on alcohol, and making sure that we're doing sort of an awareness campaign around THC as well as marijuana use. I know, again, the Public Health Commission to some degree conflicted because there are some medicinal uses and benefits on a portion of that, but there's also expected to be widespread use and abuse as well. And just want to make sure that you're on the
Yep, absolutely.
You're on your game
And
on that front. And
I mean, what we're not conflicted on, I think, at the Health Commission and at Recovery Services is
Right.
getting factual information and skills to young people and
great.
adults in the community.
Good. Thank you, Jen. Thank you, Devin. Thank you, Madam Chair.
Thank you, Councilor Flaherty. Councilor Campbell.
Thank you, Counselor Sabi George. She runs a great hearing. So I just have a couple of just follow-up questions. For this slide where it talks about Massachusetts 70, in 2017, the 72,000, could we get Boston numbers specifically? And then, which we could just email. And then going back to just trying to get a better sense of where the issue is visibly showing up, right? So obviously, I grew up on Mass Ave, so I drive down there, I'm like, this looks very different than when I grew up, where I grew up, right? Seeing people walk around using on the corner. You may not necessarily see that in certain pockets of my district. It's still there, but maybe not at the same scale. So I cover Four Corners, Codman Square, Mattapan, Grove Hall, so other neighborhoods where it's predominantly residents of color. Do we map, or is there some data, maybe it's where we're picking up the needles, or where we're getting the most 311 requests, to give us a sense where we're seeing it more acute, and then that may then explain why you have more mobile sharp team members or proactive sweeps in certain areas versus others, and then could also dictate what the strategy is to expand to those other areas.
Yes.
Could we get something sent to us with respect, like that pulls that apart a little bit?
Sure.
Okay.
Sure, we can show you a couple of efforts and how they're mapped, whether it's syringe pickup, overdose, and other things.
Okay, because that would be really helpful. And I think it might also, just when we're out in the neighborhoods, because obviously if a resident sees one needle, then the problem is too much, it's acute, it's massive. But we often have to go out and say, hey, we have a limited number of resources. People are out there doing what they can. We can't necessarily have proactive sweeps just yet in this area because we're seeing the problem more acutely here based on the data or whatever else. That's helpful in just having some more thoughtful, informative conversations with our residents. And then I would love to just see how we expand to include some outreach as you deem sort of necessary based on what you're seeing in some of these other communities. And maybe it's not all on us, but it is the health centers that are stepping up, like Codman Square or Mattapan, to help supplement or augment what you're doing, which is great. I'd love to know a little bit more of what that looks like. And then I think that was all I had. That's all I have for now. Thank you guys again for the work you're doing. I really appreciate you and your teams. Appreciate it. Thank you. Thank you, Councilor Sabi George.
Thank you, Councilor Campbell. Councilor Baker.
Thank you. So I just did the math, not to keep beating up these shops, I know, but we get called constantly on them. Clifford Park is swept 6 times a day. I get calls every day on Clifford Park. What are you doing about it? I mean, we've taken the stands down. We've removed areas that were basically public toilets. We've, you know, we have teams reaching out to people to get them into services, you know, so I'm thanking you guys because a lot of times we don't get thanked. Doing the math on it, I did it at 14,000, so 14,000 times 52 is 728,000 shops a year. That's astronomical. So good job on that, 700. No one says you picked up 750,000 shops this year. What about that one right there? So I thank you for the 750,000 you picked up, and not that one that was left over there. Okay, good. Enhanced data and revenue systems. So is that figuring out who's paying for what? Because a lot of times when you're trying to get people into services, it's just you get them there. So is that trying to just figure out who's paying for what and tracking patients or clients? Can you explain that a little bit, how it says we're substantially increased revenue? Am I right in my thinking there?
Yeah.
Yeah, so right now we provide a lot of atraditional services, so to speak, but they are billable services. And if we were to build the infrastructure to be able to track that data, like a medical record and a case management database, we'd be able to do that and bring in some revenue to increase the efforts that we're able to provide there, or to offset the city dollars. I think we rolled things out at the EC and scaled up paths pretty quickly in response to a crisis, and now we want to just make sure that all the people who can pay for it are paying for it, in addition to
So it's just figuring out who people are and who's paying what, the share. Okay, you had talked about 4 project place staff. Who is that? It's financed through a company down there. Where are they and when are they out? Do you know?
It's funded by BU. It's a collaboration with BU.
Oh, okay. So up by
and they cover,
Albany Street, or where do they cover?
No, they cover the Mass and Albany intersection up to the Southampton shelter.
Oh, okay.
And around that area, but it's fluid. I think for summer we'll be having some additional seasonal capacity put on by DPW and parks, and so we may shift the area that they
shift
cover.
them around, maybe
really
get some more people.
We sit down every other week and kind of with police and other departments and kind of go over the maps and who's covering what, and when new resources are brought on, we might shift something, but they've been a great resource, and it's been a great partnership with BU and Project Place, because it does make a difference to have those men and women out every day in uniform, helping with the cleanup efforts.
And they're picking up shops also.
Sharps
Back to
and
the
garbage,
shops.
right, and
Yeah,
trash.
okay. And you may have mentioned this a little bit. We talked about the engagement center. How many people are coming into the engagement center a day? You said right at 6 o'clock, it's capacity. Is capacity like 275, or what is?
Capacity in the space is 125.
125, okay. So we're right, and are we at 125 all day long?
No, so we'll see a big rush in the morning, and so we're usually at about 100, mid-morning. It's kind of the first stop people might make for coffee, or to brush their teeth, or just to socialize in the morning and do what they want to do.
Do they have access to a shower in there?
So we do have showers that we've just gotten online.
Oh, good.
To start allowing some showering hours too, especially for the folks who are sleeping outside, or we do have a fair share of people who work the overnight, and then they're waiting, but the shower hours for the shelter, they have to wait a little while, so it would give them a way to shower in the morning. So we're excited to get that online.
Okay, so maybe one of the holes we have in the system are those step-down beds. What are we doing with step-down beds, the city of Boston? How are we increasing our capacity, and if so, where is that happening?
We're building a bridge to Long Island.
Oh, I know that.
Hopefully.
We're going to talk about that next. We're going to talk about that next. So are we doing anything, is there anything else going on now?
I mean, there is capacity within the city, CSS and TSS beds currently, but citing any new facilities that would add to that capacity is, we haven't found a location that's willing to really entertain that, or the space to do so. So, we're putting people into those step-down services all across the state.
You want to go?
Go ahead.
Oh, okay. Can we talk about Long Island for a little while, for a minute or so? Yeah, okay. So, are we looking to do mostly step-up beds there? Can you just explain from a 30,000-foot vision of what we would like to see there, if we can. I know, and I'm sorry I didn't make earlier today. I see Chief Martinez up there, who, great job the other night at the Quincy meeting, and they probably did it there. Can we have a 30,000, if you're able to? What would like to see? Would it be step-up beds? Step-up beds go into sort of 1 or 2 year housing, GED programs? Can we kind of get a overview?
Sure. I mean, we're in the process, as you know, working with a consultant, collecting that information from stakeholders and, really doing the research and the data. And so we're pulling that all together. We've done a tremendous amount of focus groups across the region, the Northeast, Southeast, in Boston, outside of Boston, individual interviews, and really assessing the gaps in real time, but also looking ahead to three years down the road. What do we expect the gaps to be as we watch what else is happening in the state with beds being put online, but also just the major gaps around workforce development and wellness and health and the things that give people hope and stability to move forward. So all of that is being considered in a comprehensive recovery campus, which is, I mean, we can think about the details, and that's what we're doing, but really we're talking about a comprehensive recovery campus on Long Island that utilizes that space in a holistic, healing way, and has the ability with the current structures that are there to provide support and to folks in early recovery to long-term recovery.
Yeah, so that space would be where you would go for your step up and hopefully possibly stay there and get GED training, whatever it is for the client to become healthy will be offered over there is ideally what we're looking to do.
Yeah, ideally,
Okay.
yes.
So we have a little while before all that information comes back. What do you see the trends in 3 years? So what do you think is going to happen? Is it still going to be heroin? I hear a lot about meth coming in, so that's maybe a different drug. What do we see happening in 3 years? Is it going to be all, less fentanyl and less opioids and more meth? Do we have a sense of what that's going to be in the next couple of years, 3 years we'll use?
I don't think we're seeing a reduction in fentanyl right now at all. In fact, we're seeing it being integrated into many other drugs.
So the meth is just getting put on top of the...
And polysubstance use is still...
So in 3 years, we're going to be exactly where we are or worse? Yeah, I'll say that, Jen. You don't need to say that. In 3 years, it looks like...
The synthetic drug production is something that that we've been facing over the past 4 or 5 years. That certainly is daunting, I think.
Yeah.
Yes.
So just so you know, in regards to the meeting the other night, there was a counselor who would be, I guess, considered my counterpart in Quincy that got up and spoke. He grew up in my neighborhood, grew up with myself, grew up with the mayor. I've already reached out to him and made myself available to him. Anything that he needs, whatever you want to talk about, the offer was to the Quincy City Council also. So we may have to come back and get a team together and go sit with them down there, possibly. I just wanted to let you know that I'm trying to work with that Quincy City Council I've started to just make myself available if we can answer any questions that they need. So
I appreciate your support in that, and we'd be happy to join you at any time.
Yeah.
If that's what you needed.
Well, I mean, it's not, as a counselor, as a district city councilor, a lot of the talk was about spending $92 million on a bridge. The last thing that I would want to do is spend $92 million that we didn't have to spend. We have to spend this $92 million. We're getting a library in Adams Corner, $18 million. I'd rather see 5 libraries built, but we can't do that. We need to build this bridge, so let's stick together on this and keep moving it towards building the bridge. Thank you.
Thank you.
Is that it, Councilor Baker? I just have a couple of wrap-up questions from the presentation. The various placements and contacts that you've had, have you been able to extract the unique numbers? I noticed on one of the slides that it did say unique. But I'm wondering, when we think about 7,400 placements in treatment, are those unique? Or are we able to figure that out, or are they repeat individuals?
So with the investment in some of the new data systems that we're bringing online, we'll be able to tell you a lot more about the people that we are placing. That could be duplicated individuals, because that could be somebody that went to detox, 5 times within 1 year.
Great. And then in your presentation, you discussed, or you mentioned the increase in the number of folks walking in and getting treatment places, and we attribute that to the expansion of hours. Are there any other reasons why we could have increased that number? I mean, I think we all sort of agree that the crisis is getting worse, so there's more people that are trying to access help. But are there other reasons to attribute the increase in numbers?
Yeah, I mean, I think adding 33 hours a week in, treatment placement time is probably the biggest thing that changed. But we're also working really closely with our public safety partners too, who are directing people and walking people in. So I think that there's just a lot more boots on the ground that are directing people towards treatment and using PATH as a resource locally. That could also be that. And I do think the demand has gone up.
Great. And then the naloxone distribution has also gone up. Is that coming out of our operating budget, or is that grant funded?
That's totally grant funded.
And state or federal?
State.
And then do we expect that grant to continue for the
Yes.
next
Yeah.
so many years?
Yep. As well as that grant, there's been other, the Boston Fire Department got a SAMHSA grant, Substance Use and Mental Health Association, a federal grant, to work on the post-overdose response with us, and a big piece of that grant will be Narcan distribution as well, so we're coordinating with them on that. So there's the state grant that Recovery Services get, but now there's other partners that are receiving other grants and coordinating with us on reaching even more people.
Great. And then with the engagement center, are we able to measure any of the accomplishments? Is it increasing the number of individuals that we're getting into detox, into other programs, other treatment? Can we see that that's helping at all? Because one of the things that I've heard from constituents in the area is that sometimes it attracts individuals who are either dealing or using. There might be a bad or a very negative reaction to whatever it is that they're on, because we don't always know what people are on. They don't always know what substance they're using. Could we reference maybe some of the success stories out of the engagement center?
Sure. I think what the engagement center has done best is to improve the quality of life of people who are down there and on the street. I think people have a place to wash their hands and to see a nurse and to get food and to stay warm when it's cold and to be in AC when it's really hot. And they're avoiding injuries in that way. And I think it's just the social connection. I think for some people, as they become more contemplative about recovery and making change, the more social connection they can get from staff. And it might be a touch point over time, 3 weeks, 3 months. It helps to move people along the continuum of readiness for change, or to ask for help. Hey, can you help me find my housing worker? I'm ready to get back on the housing list. I'm ready to try again. I think that's what we're seeing the most. And again, with investments in more data systems, we're hopeful that we can demonstrate that more with data. We were very cautious when we opened the engagement center, as you know, to have it be as low threshold and low barrier as possible, because we really wanted people to come in. And I think we've established that now within the community. So I think we can start, lightly triaging people a little bit differently to find a little bit more about where they're coming from and their needs.
Great. And then can you share, one of the things that I've heard a lot about in our work, and I think it's talked about in rooms that we're all in, is the lack of recovery beds or step-down beds post-detox. What is the number that we need when we think about the crisis that's hit us here in Boston?
I think it's hard to pinpoint a number, but certainly we're not anywhere near that number, that we still have 4, 5, 6 month waiting lists for residential care. And I think that's part of the thinking that we're putting into Long Island as far as the master planning. How can Long Island be a resource to not just Boston, but the region, because we do see so many folks from outside. And if we have the ability to put it really provides us with the ability to put a significant number of treatment beds to resolve some of this, some of how people get siphoned through and squeezed and wait. And we know that with addiction, people can't wait. When they're ready, we need to get them the care that they need.
Do you think it's a few hundred or a few thousand?
I would say it's in between.
That's 500.
No, I think it's 2,000. The number that I hear, because I ask that question pretty frequently to people who are immersed in this work, and maybe you're just not in a position to say, but we hear 2,500 is the amount of recovery or transitional beds that we need in the state. I mean, it's a statewide issue, but here in Boston, we know that we're feeling the brunt. Well, I guess maybe I'm not sure the description of the type of bed, but it's where people who are dealing with addiction, substance use disorders go after detox. And it can't be home on the couch. It can't be on the corner of Mass and Cass, because then we're dealing with someone who continues to spiral, and we're not giving them the services they need. It's that wherever that next step and stop is. Any update on the lawsuit that the mayor has filed against?
No, it's pending, right? No, it's pending.
Okay. Councilor Baker?
Yeah. Is there any place in outside of Boston that has a PATHS type program, or is Boston the only one? Has any place else replicated it or tried to replicate it?
No, PATHS is a fairly one-of-a-kind program, and so we're aware that the goals for PATHS has to change a little bit so that we're out in the community providing more TA on how you do this work.
TA?
Technical assistance, because really anybody can get somebody into care,
Right.
especially health centers and hospitals. There's no reason people can't do this a little bit better. And so we, partnering with the state, keep track of where we feel like people aren't getting referred as they should be. But also try to think about where can we do more trainings and reach out and provide some assistance to keep people where they're at and to get them placed directly. So we've had a lot of people come visit from different parts of the state, and I think that's positive. And so that's certainly a priority of ours is to make sure more people start providing these services in other parts of the state.
Okay. And home visits after overdoses, how do we connect on those? Is that emergency room data? Or how are we connecting on to that person? Who does that?
Yes, the recovery services staff, along with the Boston Fire Department EAP team, meet regularly and respond to those addresses.
Yeah,
where
okay.
overdoses
So if
have
there's a
occurred.
call on it, we know who the person is and where they're going after they come out of the emergency room or wherever they go. That's how the follow-up is.
Yeah, the follow-up is at the address where the event took place, because it's based on the police data, the 911 data that's available. And so sometimes when we do that visit, it's not the person who had the overdose. It's mom or dad or roommate who also needs a talk and services generally, because they haven't necessarily talked to anybody else about what happened and some safety planning. But we do also meet with the individual when they're there, or people follow up with us later, and so we have been able to get people into treatment that way.
Yeah, that seems like that might be difficult to do, like the house visits if they don't have any place to live. What is the Squad 80 EMS? That's a quick response team? Can you just talk about it briefly?
Yeah, do you know?
Squad 80 through EMS?
Right, and I mean, I think it's best answered by Chief next week when his.
Yeah.
But it's a rapid response team in high volume areas to relieve ambulance.
Will they be specifically down the Mass and Cass
They're
area?
down. They're there.
They're there
yes.
now.
Yep,
They're there now.
That was last year's initiative. I believe.
Okay. Do we have a sense of what the long-term for the engagement center is going to be? Do we have any sort of thought building a real building there, maybe doing that long-term? Are there any discussions on that?
Yes, we're having those discussions right now.
Replace it where it is, building?
Yes.
How far along are those discussions?
we're working with a consultant right
Yeah,
now
just
to do a
so-
site study. And so the site study comes first.
Yeah, and then design, then.
Design, resources.
And my last thing is the youth prevention strategy. So is that group that we were at last night, Jenna, is that one of the groups that you guys helped to fund?
So we actually don't fund that group, but this is the exposure that the community prevention team has, the impact that they've been able to have in building partnerships. So that group reached out to us and asked for support in developing the idea. It's Prevention Week.
Yep.
And so they wanted to do something. And so now that we have a team and folks that are able to work with community providers, we really just sat down with them and said, you know, what would this look like for you and your community, and supported them. And then they did all the heavy lifting, and we supported the effort. So
I think it's important. And my last, just throw it out there, if I could get, and people I think asked for it earlier, just the actual number that's going in those kiosks at Orchard Park and the one outside the Mason. So it just got landed maybe a month ago or so, so what the weekly totals are when you get a chance.
Sure.
Thank you, ladies.
Yep. Thank you.
Thank you. We don't have many public testimonies, so I appreciate you both being here and sharing this information with us. I know we all look forward to some of those follow-up pieces of information. Thank you for your work that you do every day. I think really on behalf of all the residents of the city, but really for those that are most vulnerable. Thank you. This meeting is adjourned.
Thank you.